Actually did a great job of actually highlighting several of the key abstracts that were presented at AASLD predominantly and a few at DDW. And we coordinated, so I'm not going to repeat any of them, and I'm going to just cover a couple of themes related to both HCV and HBV. So to start with, the key areas that I wanted to just touch base with in terms of HCV is to look at, there's kind of an evolving effort to shorten DAA therapy. We already have therapies that you can treat treatment-naive patients for just 8 weeks, and you can see in the studies that are being done that there's an effort to sort of move towards shorter duration therapy of 8 weeks with other drugs, so I'll look at those. I'm going to touch base on some of this, what I'm going to call treatment populations that are special. We don't really call them difficult to cure groups anymore because for the most part, we can cure most patients. And to talk in that regard a little bit about sort of some of the evolving areas of treatment, which include persons who inject drugs, and then finally I'll touch base on the DAAs and liver cancer, and that's what I'll cover for HCV. So this is, if you look at the AASLD guidelines, this is the current therapies for somebody who has HCV, is treatment naive, and is non-cirrhotic. So this is our easiest group of patients to treat. And we have really, the 4 drug combinations listed here are all approved therapies. What I did in this table would just highlight for you the therapies that offer the 8-week option, because that is kind of, I think, a little bit of the trend is to look at that 8-week option. I think providers find it very easy. It's only 1 refill, and I think patients find the idea of 8 weeks attractive. That being said, all of the other treatments that are sort of blocked out on this slide are typically 12 weeks, which is not a huge difference. But I just want to sort of highlight the 8-week option. And really what we have is Glecaprevir, Pibrentasvir is the one drug for which we have a pan-genotypic option that's 8 weeks in duration. And Sofosbuvir, which has been around a little bit longer, we've had that option for genotype 1 patients, but within a select group. They have to be having a viral load under 6 million, they have to be without HIV and be non-African American. But in that group of patients, studies have shown that if we treat for 8 weeks, we can achieve an SVR rate that is the 95 to 97% that we expect with our current DAA options. So at the meeting, there's an effort to look at other drug combinations, especially in genotype 1 patients, that we could use also 8 weeks. So here's one trial using Elbasvir Grazoprevir. So that is an approved therapy for genotype 1. In this study, they look specifically at genotype 1b. And why 1b? Well, it is the easiest to treat genotype, that's part of it, but also with Elbasvir Grazoprevir, if you're genotype 1a, you actually have to do RAS testing, and the RAS testing determines your duration of therapy. So it's sort of simplified with 1b. And the short kind of message here is that, as you can see in this study, when they treated with 8 weeks in this group of patients, again, non-cirrhotic and treatment naive, you can see that we can get SVR rates of 97%. Sort of suggesting that when we move to this sort of easier to treat group of patients, that really maybe some of our treatment options that are currently 12 weeks could be in fact shortened to 8 weeks. Another example, here's Sofosbuvir Velpatasvir. This drug is also a pan-genotypic option that we have, but currently is approved only as a 12-week regimen. In this particular study, they selected treatment-naive patients. They allowed them to have fibrosis up to F3, which is consistent with, again, a non-cirrhotic population. And they focused on genotype 3. And you could argue, well, why didn't they study all genotypes since this is a pan-genotypic regimen? And I think the answer is genotype 3 is actually our most difficult to treat genotype. So if you can sort of prove in genotype 3 that 8 weeks would be sufficient, perhaps you could say it's likely to be effective across other genotypes. So here you can see, again, a very excellent SVR rates. On an intent to treat basis, it was 93%, and on the modified intent to treat, meaning those that completed therapy, it was 100%. This is also a noteworthy study because they're studying it in a group of patients where we increasingly want to see treatment being used, and that's in individuals who are on opiate substitution therapy. It's recognized that if we're going to do elimination of HCV in California and the United States, we have to increasingly move into individuals who have the highest prevalence of infection and who are ongoingly at risk for transmission to others. So in this particular study, 91% of patients were also concurrently receiving opiate substitution therapy. And you can see that, again, we have very excellent response groups, both with this 8-week regimen and in this group of patients. And you could argue that this might be the one group of patients where we really do want to see a short regimen being used, because oftentimes those individuals may be less engaged in care, and so getting a short regimen might be particularly beneficial. So the sort of take-home message is sort of looking to the future. I think there's this interest in trying to shorten therapies in this very specific group of patients, which we now view as being the easiest to treat. Those that are treatment naive, non-cirrhotic, that's the group where we're looking at the 8-week regimens. And individuals currently that are coming to me in the clinic are generally treatment naive. All the patients that were in my practice have largely all been cured already, so the newly referred patients are generally those that are treatment naive, and many of them are in fact non-cirrhotic, so we have an increasing group of patients for which we can potentially be offering an 8-week regimen. What I show in this table is the fact, the guidelines haven't changed, of course, with this new data, but I would sort of say, looking to the future, that you may see more of the regimens have an 8-week option. Clearly, more studies need to be done. But I think it's very reassuring to me as a treater, because every once in a while I have patients who are supposed to get 12 weeks and they don't do their last 4 weeks, or something happens and they don't complete their therapy. And I think these data are very reassuring because they tell us that probably 8 weeks is going to be enough for most patients. And so I think it's reassuring data for that point of view. Now, I mentioned to you that genotype 3 is our most difficult to treat genotype, and in particular genotype 3 with cirrhosis. So if you have to line up all the patients that we have to treat, this is the one group for which we really struggled to get the same SVR rates as in other subgroups. And that's really the one that sort of has been the remaining one in the DAA era. And as you can see here, I've put the AASLD IDSA guidelines up here. And you can see that for non-cirrhotic patients, we have 2 options that are recommended, Glecaprevir Pibrentasvir for 8 weeks and Sofosbuvir for 12. And on the compensated side, generally when you move to cirrhosis, you can't use shortened duration regimens, and you can see that both GP and Sofosbuvir are 12 weeks. But the little asterisk is what I want to focus on here, is that for Sofosbuvir, it's recommended that this is one group of patients that you actually have to do RAS testing before you do treatment. So you have to test them for resistance-associated substitutions, and if the patient has the Y93H mutation, which is a mutation that we know can exist at baseline and certainly can become also prevalent as patients are become experienced in treatment. But if that RAS is present, then the guidelines say you have to add ribavirin. So adding ribavirin, you could say, well, that's no big deal, but actually ribavirin is the one drug these days that still carries with it a significant amount of side effects. So most of us typically are wanting to avoid use of ribavirin. But the reason that the guidelines actually make this specification is, as you can see in the ASTRO-3 study, which informed the guideline, that the SVR12 rate in those genotype 3 patients with cirrhosis treated with Sofosbuvir for 12 weeks, if they had the Y93 RAS, their SVR rates were only 84 compared to 97% if they didn't have the RAS. So that's why we had to do the testing. But clearly, there was an interest, I think, in seeing if this was real, and whether with more results we would see a different outcome, because that was a really sort of a modest-sized study. So one of the important studies presented at EASL this year really is a larger randomized open-label study in which they specifically focused on genotype 3 with cirrhosis, and they randomized patients to getting Sofosbuvir with or without ribavirin for 12 weeks. So that was the intent, and really to sort of definitively decide, do we really need to add ribavirin in these patients or not? And the short answer is, yes, we do. So shown on the left is the overall, and then in the treatment-naive and treatment-experienced population. And in the Sofosbuvir plus ribavirin group, you can see the SVR rates are higher than those overall than those with got Sofosbuvir. And it's really defined by an increasing number of relapses in the patients who got Sofosbuvir. And shown on the table on the right is, again, the impact of the baseline RASes. So again, shown in red, in the Sofosbuvir group, if you had any baseline RAS, your SVR rate was 84, but really if you have that Y93H, it was only 50%. Of course, the numbers are very small. But the bottom line is that the RASes are still impactful in Sofosbuvir patients with genotype 3 and cirrhosis. So if you're going to use that combination, you've got to do the RAS testing to know whether you add ribavirin or not. Now, I will say that the guidelines also say that you can switch to an alternative regimen in that setting as well. So that's the other thing, of course, to consider. Okay. So that was just sort of sort of where we are with sort of our standard treatment, but I'm going to sort of spend a few minutes talking about the DAA treatment failures. So most patients, when we walk in the office and we offer treatment, we say 95% chance you're going to need 1 round of treatment and you'll be cured, because that's what we can achieve with almost any of our regimens these days. But there is that 5% who fail, and they fall into a sort of special group, I'll call, of DAA treatment failures. And honestly, I think we don't really know why a given patient fails. We know there are some factors that are associated with failures, but I continue to be amazed at patients that I would never have predicted would fail come up as failure. But the things that have been linked with treatment failure include the presence of cirrhosis, PPI use for some patients with some combinations, IL-28B, which is really a marker of innate immune responses in some settings, has been shown to be important, certainly adherence, certain genotypes, and of course RASes. And in the end, it's probably not one thing, but actually a multiplicity of negative prognostic factors that actually lead to an individual patient failing. Now, of all of the negative factors, the emergence of resistance-associated substitutions are probably the most important. And whenever a patient is treated with a DAA regimen, they will get resistance-associated substitutions almost certainly as a consequence of having been exposed to the classes of drugs. And of the different kinds of RASes that can emerge out of a prior DAA therapy, the ones we are most concerned about are NS5A RASes. Because that class of drugs, when you get those RASes, when those resistance-associated substitutions emerge, they stick around for a long period of time, years. So generally, you're going to be dealing with that resistance-associated substitution for your next treatment regimen. Okay. So don't even look at this table, really. It's made to highlight that it gets complicated when you start to move into DAA-experienced patients. So you can see this is the AASLD guidelines. The guideline actually doesn't recommend that we do RAS testing. It just says look at what they were treated with before, and whatever their treatment regimen is, whether they got exposed to a protease inhibitor, an NS3, or whether they got exposed to an NS5A inhibitor, that's how you make your decisions. But the intent in showing you this table is to say it's complicated. You can see that you have to know the genotype, you have to know a little bit about what they were exposed to before, and obviously there's not a lot of choices really as we sort of think about this. And I'm going to focus on the NS5A column, which is in bold. So this is a patient who's been exposed to an NS5A, and they could have been exposed to other drugs as well, but it's the NS5A that matters here. And as you look down the column, you can see that basically the drug of choice here is Sofosbuvir. So Sofosbuvir is a combination of NS5B, NS5A, and a protease inhibitor. So we've got a triplet. So basically, every drug class that we have has been put into this combo as our rescue strategy. And you can see that for genotype 3, again, that most difficult to treat genotype, we are actually, that's the one group where indeed we're being asked to consider using ribavirin in the more difficult to treat group. But we have other high potency DAA combinations, and Glecaprevir Pibrentasvir is sort of one in which there's the NS5A and PI are known to have high potency. And so the question is, do they have a place in the treatment of patients with NS5A experience? Indeed, in the AASLD guidelines, Glecaprevir Pibrentasvir for 16 weeks is recommended as an alternative regimen, for example, for genotype 1. And so I'm going to show you some data that came out of the meeting that focuses on that particular combination, because it's more, do we have other options for our patients who are DAA experienced? So this is a HCV target study. It's an interim analysis of a phase 3 study. You can see they focused on genotype 1. These are all patients who had been previously treated and failed with an NS5A inhibitor plus Sofosbuvir. And in this study, they were randomized if they were without cirrhosis and with cirrhosis to either getting 12 or 16 weeks of treatment. The SVR4 results are shown in the bar graphs at the bottom. So SVR4 is not SVR12, although there's a high degree of concordance. And the point to make here is that for the individuals without cirrhosis, the 12 and 16-week regimens look comparable at this point in the analysis. So that's important new information, because the current guideline says that we should use 16 weeks. And of course, we like to use shorter whenever we can. In the cirrhotic population, you can see that the group that got 12 weeks with ribavirin sort of was suboptimal. And so that actually was discontinued, and the Glecaprevir Pibrentasvir for 16 weeks has a very good SVR rate, as you can see. So this study is still in place, but I think it will help to inform our guidelines in terms of, in particular, the duration of therapy in the genotype 1 non-cirrhotic group of patients. Now, I think another kind of, one thing I'll just highlight with this table is they went also in the presentation and highlighted the NS3 and NS5A RASes that evolved out of patients who failed Glecaprevir Pibrentasvir plus or minus ribavirin. My point in showing you this table is only to say, as patients fail therapies, they just keep getting more RASes. So that's my point. They become a more difficult to treat population every time they fail a DAA therapy, which is why as treaters we want to make the best choice in terms of what we go with first, because we want them to be a success. So shown here in this table, you can see the individual results, but basically from the baseline to the failure, you can see they're accumulating these RAS mutations, which is going to make their next treatment regimens even more complex potentially to manage. So just to point out that that's the role here as treaters is to pick the best regimen, treat them once so that they're a success. Okay, but one of the other, I think, exciting combos to potentially be looking at for treating our DAA failures is the combination of Glecaprevir Pibrentasvir plus SOF, and in this case, they also looked at adding ribavirin. So this is like throwing the kitchen sink at our patients who have failed a prior regimen. So here they're looking at that triplet, so GP, SOF, and they also used ribavirin here. These were in patients who had previously failed a GP treatment. They tested 12 versus 16 weeks. Here there are not very many, and you can see in the bars that are on the right that not very many are in the 12-week arm. This is primarily 16 weeks, but the SVR rate is very good. So this suggests that we have potentially another rescue option for our patients, and in this particular instance, patients who previously failed GP. And there was also a multi-center compassionate access study from France that also looked at GP plus SOF. This one did not use ribavirin. They only treated for 12 weeks, and these were in a whole kind of heterogeneous group of patients who'd previously been treated with DAA-Exp'd. The numbers are modest, but that's because treatment failures are not that common. But the encouraging thing here is that they showed that the SOF plus GP regimen yielded an SVR rate in 100% of their patients. And so it's interesting that the AASLD guidelines in terms of management of DAA failures is different from what the AASLD and IDSA is recommending. They've sort of simplified it. But I really like their strategy of sort of thinking about DAA failures in terms of level, or I would say risk of subsequent failure. So starting at the top, if you have a patient who's failed a DAA regimen but doesn't have cirrhosis and has only failed one other regimen, they suggest that you could use SOF-Valvox for 12 or GP for 16 weeks if the 16-week regimen with GP for those that have failed an NS5A only. But you can see as you move down the triangle to patients that inherently have a greater risk of failure, so now they have advanced cirrhosis, or they have complex RASes, or they failed more than one regimen, then you have to move to sort of adding on. And the adding on usually means you want to have a drug for, that's going to cover each of the classes. You add ribavirin, and in some cases you extend treatment. So I can tell you I've had patients that are now in their 4th regimen of being treated, and they generally are falling into that group where we're trying to give them something like SOF, GP, plus ribavirin for 24 weeks. The idea being we're giving them everything we've got to try to get them cured. So this is sort of the emerging themes, I think, related to DAA failures. My last thing that I want to just touch base on in the treatment regimens is this need to treat persons who inject drugs. So you're all very aware of the opioid epidemic here in the United States. We have this marked increase in new infections among 20 to 40-year-olds in both the rural and urban areas. And shown in red are the states that have had a 200% increase in the number of acute HCV cases. California falls into that group. And so with the goal of having HCV elimination, we're now very much kind of pushing towards, we got to treat individuals who are newly infected, and we got to treat persons who inject drugs, not only to cure them, but also prevent them from transmitting to others. So this treat to prevent strategy is paramount. So there's a lot of literature and presentations coming about how to do that well. This is one that was presented at the AASLD meeting called the Anchor study. And it's just emphasizing the importance of co-locating HCV and opioid substitution therapy in the same place. And I think increasingly we're realizing that if we really want to treat individuals who inject drugs, you can't just treat their drug use. Can't just treat their Hep C. You also have to, make efforts to treat the drug use. And it's only with harm reduction plus HCV treatment will we actually get a reduction in the number of infected individuals. And this is really just to show the success of being able to do this. So in this study, they were treating individuals, and they encouraged them to do the buprenorphine at the same time. They weren't required, they just invited them to do so. And what's interesting is they looked at visit adherence as a marker of kind of the engagement. And individuals basically completed treatment for the most part. They did have some people lost to follow-up, but in this group that was actively using, it's good to see that we still, in individuals who actually take the drug, we get very high rates of SVR. So shown on the figures is the proportion that if you do a per protocol analysis, 91% got SVR. But the other interesting thing is they were looking at risk behaviors, and they used an HIV risk behavior questionnaire, and they showed that engaging them in HCV treatment, and then also if they also got opioid substitution therapy, that we also saw a decrease in risk behaviors, and ultimately we hope that's going to translate into getting less HCV transmission. So a couple of messages. HCV genotype 3 with cirrhosis. I showed you the data. The new data says you still need to do RAS testing if you're going to use SOF-Val, or you can switch to SOF-Val-Vox or GP. DAA experience, they're a complex group of patients. I think we're getting some good options there, but they remain one of the challenging groups, and thinking about moving into PWIDs. My last is really about the cancer issue. So I think Paul very nicely outlined that you treat individuals with advanced fibrosis and you reduce their risk of getting cancer by about 70%. So that's an amazing feat to treat someone and get that kind of cancer reduction. But they're still at risk, and the quoted number that you can give your patient is after cure, your risk of cancer is probably 2 to 3% per year. Now, it might be much lower than that for some patients, and we're now starting to understand who's at risk for getting cancer after cure. And the themes are that clearly those with more advanced cirrhosis, so those that were decompensated cirrhosis, Child-Pugh BC, have higher rates than those that are Child-Pugh A, patients who are older. And then what I want to emphasize by the study I'm going to share with you is the importance of coexisting NAFLD, and I think probably within that is the presence of diabetes. So this is a very interesting study. They were focused on trying to assess whether they could see reversal of cirrhosis using liver stiffness, but they also, in the context of this, looked at kind of the rates of complication after curing a group of patients who had a range of fibrosis. So they weren't all cirrhotic. 40% of them had liver stiffness scores greater than or equal to 12. 60% were non-cirrhotic. And you can see they're following them forward, and among their patients, they did identify patients who had decompensation and liver cancer. The really important take-home message from the study for me is they did their analysis of what were the factors that were associated with getting cancer after cure: age, being male, and diabetes. And diabetes came out as being one of the key factors associated with the risk of getting cancer after cure. And this is across the board in cirrhotics and non-cirrhotics. And they sort of came up with an algorithm based on their results that suggested that if you were male over the age of 55 and had diabetes, you had a much, much higher risk, for example, of getting cancer than a patient who didn't have those factors. And the take-home message for me in terms of how this is changing my practice is I have to say that I'm now hanging on to the patients that I cure who have a moderate amount of fibrosis and have diabetes. And we are definitely implementing HCC surveillance in those that have stage 3 fibrosis, so bridging fibrosis. And my guess is over time we actually may go down in terms of doing a broader range of surveillance in that patient population that's older and has diabetes. So diabetes, mark my words, is going to become the new big risk factor for liver cancer. Now I have 1 minute left, which is just perfect for Hep B. Well, you know, I think Paul showed you all the great new drugs, but they're not really here yet. And I'm going to give you just 2 major concepts. There is a lot of talk about cure now, which is super cool. And you're going to hear the words partial cure, functional cure, and sterilizing cure, and I'll just make it clear what they are. So partial cure is basically an inactive carrier. It's somebody who still has surface antigen, but their HBV DNA is persistently undetectable. And with current therapies, we certainly can achieve partial cure frequently. But the emphasis now is on functional cure, which is where you lose surface antigen. And then sterilizing cure is when you get rid of virus from within the nucleus of the liver and also integrated. And honestly, we don't have access to that at the moment. So you're going to hear about partial and functional cure a lot. So I'm going to just give you, I think there's a couple of nice studies that were presented. This is from one of the, this is from the Stanford group. And really what they're doing is sort of outlining for us, well, what's the real world rate of losing surface antigen, of becoming functionally cured that exists? And the answer is, we know the number now. The number is 1% per year. So among chronic HBV patients, over their lifetime, 1% per year will lose surface antigen spontaneously and or with treatment. So that's a very low number, right? So we have a high bar if we want to get more functional cures. So how are they doing it? Well, there's sort of two major strategies that are being used to try to get more people to lose surface antigen in the context of therapy. And one of them is to do an add-on or switch if somebody's on a nucleoside analog, either add or switch on PEG interferon. And I think the kind of exciting one is this withdrawal of NA therapy. So I'm going to just take one extra minute to do this. So this is the SWAP trial. It comes from Asia, in which they take patients that are on nukes, and they either switch them to PEG interferon for a period of a year, or they add on interferon for a year, and then they stop everything and look to see what happens. The baseline characteristics are shown there. They're fairly comparable across the groups. And the take-home message here is that you can see that by doing the switch or the add-on strategy, you do get more people to lose surface antigen than if you just keep treating them with a nuke. So in this study, when they looked 1 year after stopping the whole strategy, about 15% of patients had achieved surface antigen loss, in contrast to those that kept taking their nuke, the nucleoside analog, they didn't have any. So if you want to get more surface antigen loss, you got to do something else, and usually priming the immune system with PEG interferon seems to be one way to go. But I don't think we're going to get a lot of takers on that in the US, because people just generally don't like using interferon. So the other strategy that's being done is people are just stopping nukes in patients and sort of finding out that by doing that, you actually get more surface antigen loss. So this is a study from Asia, and the short answer is they did a propensity matched analysis, which is very nice. But these are patients that were on long-term nuke therapy, were E antigen negative and HBV DNA negative on their nuke. And then they just stopped and observed what happened. And you'll see that the curve on the right shows that the group that stopped versus those that kept taking their nuke, again, those that stopped are more likely to lose surface antigen. The number is about 20% after up to a period of several years. In this case, they're following them out to 10. They also showed that the group that stopped the nuke was more likely to have less cancer and actually have a better survival. So I'm going to show you two brief studies, and just to make the point that there's now several studies in which you take patients that are E antigen negative on a nuke for several years, stop the nuke, they get a bit of a flare, and then they settle out, and more of them lose surface antigen. And the number is very consistent across studies. Here's one from Europe, and here again you'll see they stopped it. These are all non-cirrhotic patients who'd been on entecavir or tenofovir. They stop it, and then they follow them out. And you can see at 12 months after stopping the drug, 20% of their patients had lost surface antigen. Much, much higher than if you keep them on the nuke. Similarly here, this is another study from Spain. Again, stopping the nuke in patients that were E antigen negative, HBV DNA negative, non-cirrhotic, 20% of them, after a year, lose surface antigen. So this is a way for us to get a high proportion of patients that achieve functional cure. Now, the guidelines don't actually endorse this. So this is the take-home messages. I think you're going to see more and more people talking about surface antigen loss as the endpoint for therapy. It isn't good enough anymore just to have them suppressed in terms of their HBV DNA. Now we need cure. So you're going to hear much more about functional cure, this need to lose surface antigen. And right now with the strategies that are being considered, it's about 20%. Whether you decide to do the add-on switch with PEG interferon or to stop the nukes in that subgroup of patients that have been suppressed. But my final slide is just going to say it's not, despite all the data I showed you from the meeting, basically the guidelines doesn't really endorse it. We sort of say you can consider it, but we really favor keeping patients on nuke until we have more data. So it's sort of emerging. I think it's going to change in the next year or so. Next several years as more studies become available, but it's, I would say, not quite ready for prime time. But if you decide to stop that patient who's E antigen negative, who's been suppressed for many years, my advice is just to be really, really careful in terms of the monitoring, because they do flare and you've got to be prepared to restart treatment if that happens. Okay, that's it. I'm going to not carry my last one. I saw that one already anyway. Thanks. And
thanks, Dr. Terrault.
Yeah, my pleasure.
We're going to do a computer swap. So